in children and young people and the role of pharmacists in early detection and prevention. And that's certainly a very important topic to discuss because the cardiovascular disease often begins early in life. And even though dyslipidemia in children and young people is a growing risk factor, it is yet under-recognized. And to talk to us about that and more, we do have a great lineup of amazing speakers for you today who will share with us their knowledge, insights, and practical experience on those topics. And I will be introducing them very shortly. But first, let me introduce myself. I'm Sherif Guorgui. I'm a pharmacist from Canada and the president of the community pharmacy section of FIP. It is my pleasure to be your moderator for the webinar. And also with me today from FIP are Ines Nourish Dakuna and Albin Alabib, who are doing all the important work in the background to ensure that everything goes smoothly and that you enjoy your learning experience with us today. And we also have with us Murat Becik from the Turkish Pharmacists Association, who is supporting this webinar by offering live Turkish translation. And if you would like to listen to the webinar in Turkish, just follow the direction on the screen here. You can just click on that globe icon that the green arrow is pointing to and just follow the prompts from there. And thank you again so much for the TPA for your support with that. And if you would like to follow along with translated captions in your preferred language, now you can also do that with this new live translation feature on Zoom. If you would like to try it out, you can just follow the instruction on the slide. They are very straightforward. Just click on the closed captions icon, enable the translation toggle, and choose your language. Before we start, we have a few housekeeping points. Please note that this event is being live streamed on FIP YouTube channel, and it is also being recorded. And the recording will be available afterwards on our website at events.fip.org and of course on YouTube as well. If you're joining us live, we welcome your engagement. So please feel free to send any questions that you may have through the question box throughout the webinar. And we will also go through all the presentations first, and then we will be opening the floor for discussion with our panelists. And that's when we will get your questions. And we will always do our best to ensure that all of your questions are addressed. Your feedback is very important to us. If you wish to provide any comments on this event in particular or on our digital events in general, please send your comments to our email at webinars@fip.org. It is very important for us to not only know what we're doing right, but also to know what we can improve on. So please do take a moment to share your feedback with us. And lastly, if you're not a current member of FIP, I would like to take this opportunity to invite you to become a member and to join a global network of colleagues from all over the world. To learn more about the membership benefits and to become a member, please check our website at fip.org. For our program today, we will be learning about dyslipidemia in children and young people. What are the definitions, risk factors, and trends? We'll learn about the screening and early detection opportunities in pharmacy practice, the role of pharmacists in promoting cardiovascular health, and the challenges and opportunities for pharmacists in cardiovascular disease prevention. And if we do our job right, which I'm sure we will, by the end of today's session, you'll be able to describe the types, causes, and trends of dyslipidemia in children and young people, identify opportunities for early detection and screening in pharmacy practice, recognize the pharmacist's role in health promotion and lifestyle counseling, and understand the challenges and potential solutions for implementing pediatric screening services in pharmacy. So we have a panel of really amazing speakers today. Katarina Fehir from Croatia, Jorge Robledo from Argentina, Nisligul Özdemir Ayduran from Turkey, and Victoria Cardenas from Spain. I will be introducing each of them more properly before their individual presentations, but I just wanted to take this opportunity now to thank them for taking the time to prepare their presentations and for being with us today to share their insights and expertise. And with that, it is now my pleasure to introduce our first speaker, Dr. Katarina Fehir. Dr. Katarina is a pharmacist and assistant professor at the Faculty of Medicine in Croatia. She also works in a community pharmacy, combining academic teaching, pharmaceutical care, and public health engagement. Katarina, thank you for being with us today, and I will now turn it over to you.
Thank you very much for your introduction. Thank you all participants today on a webinar, and thank you also FIP for support this important topic. Today, like you heard, we will discuss about cardiovascular diseases and dyslipidemia, and I want to start my presentation with question: why is early detection of dyslipidemia important? First of all, some international studies indicate a growing prevalence of dyslipidemia among children, and another data sets, such as longitudinal study from Argentina, suggest stable rates over time. This discrepancy reminds us of the importance of the context. Firstly, geographic, socioeconomic, and of course, some methodological factors when we interpret prevalence of data. Secondly, for us who work in the pharmacy or academic settings, this underlines the need of critical approach of regional data before we discuss about trends. Secondly, public health importance of early detection is also very much important. Dyslipidemia is often asymptomatic, yet it's a major precursor for arteriosclerosis, cardiovascular diseases. So this creates opportunity for pharmacists and healthcare educators to advocate for routine lipid screening and educate both and the public and healthcare teams on prevention. So it's very big opportunity for us. When we discuss about dyslipidemia in children and when we look at global perspective, like I said, it's growing global health concern and rising global public health issue, of course. It's not only due to the rising obesity rates, but also shifting dietary patterns, lifestyles, and this is something we need to be aware. Now, while this might sound alarming, it is a significant opportunity for early detection and early action. Evidence supports that the implementation of early screening strategies, particularly in primary care settings and school-based health programs. So we all invite to be participate in this. However, we need to be focused on addressing health disparities, particularly in low and middle income countries. Sorry. This slide presents the reference intervals used to interpret lipid profile in children and adolescents. These cutoff values help us to classify lipid levels as accessible, borderline, and high. And this is essential for guiding clinical decision, especially in preventive cardiovascular care. So let's go through parameters. First, total cholesterol alone is not diagnostic, but it's useful first step in screening. If we see levels above 5.2 millimole per liter, this is classified as high and should prompt further evaluation. LDL cholesterol is the most critical value in assessing arteriosclerotic risks. Triglycerides, they are age-specific and elevate these parameters result from diet high in sugar, overweight, obesity, or underlying endocrine disorders like diabetes mellitus. What is important here is that even borderline values shouldn't be dismissed. They represent an opportunity for early lifestyle intervention, particularly in children with other risks like poor diet, physical inactivity, or family history. This slide highlights two interconnect but distinct issues in pediatric dyslipidemia. First, we have familiar hypercholesterolemia, and it's a common but significantly underdiagnosed genetic disorder. According to some study, familiar hypercholesterolemia affects 1 in every 200-500 people. But another study from meta-analysis from 2020 suggest that and show that heterozygotes familial hypercholesterolemia prevalence in children is 1 and 364. So this is suggesting the need for early detection and ideally even before adolescence. Now, the right side, dyslipidemia and obesity in pediatric population, it's well documented, and 20 to 40% of overweight or obese children show some form of dyslipidemia. But here we need to be aware the key point for clinic practice that obesity is not only a risk factor. There are normal weight children with significant lipid abnormalities, and often due to genetic conditions like we said, familiar hypercholesterolemia and metabolic factors. For example, we have cohort data from Argentina found that not all obese children had lipid abnormalities, and some children with normal body mass index did. So what does mean to us? We must advocate for individual lipid screening, not just screening based on weight or appearance. Pharmacists are in position to identify family history, consult caregivers, and of course refer at-risk children for testing. So I think we have opportunity here. This slide is just a simplified overview of two main types of dyslipidemia. Like we said, primary genetic example is familiar hypercholesterolemia, and secondary dyslipidemia result from lifestyle factors or underlying comorbidities such as obesity, type 2 diabetes, hyperthyroidism, or chronic kidney diseases. Understanding the cause is essential because it determines both the treatment approach and need for family screening. Pediatric dyslipidemia is growing global health concern, like I said in the introduction, with prevalence rates varying widely across regions from 10% in parts of Europe to over 25% in Asia. So while urbanization, diets, and rising in childhood obesity are common drivers, we need to be aware of regional disparities in screening. So for conclusion here, to effectively address dyslipidemia in children and adolescents, a region-specific evidence-based approach is needed. And one of these combines early screening, public health education, and pharmacy-led interventions. So this is a map from data from PubMed, how the prevalence look like in pediatric dyslipidemia. But most important is why is early detection important and why it is matter. Because a crucial point is that arteriosclerosis begins in childhood. And we have great data from Bjelovar study where they found the fatty stickers appear as early age and 10 to 14. So it's a very big and important data. We also know for lipid tracking studies that around 50% of children with dyslipidemia will retain these abnormalities into adulthood, and significantly rising their risk for cardiovascular diseases. Major risk group is, of course, obesity, diabetes 2, familial hypercholesterolemia, family history of early cardiovascular diseases. Based on expert panel of integrated guidelines for cardiovascular health, they recommend the screening should be universal at age 9 to 11, and again 70 years to 21 years old. And selective from age 2 onward is high if they have high risk of factor and presents. So globally, the problem is worsening in low and middle income countries, and we need to be aware. And finally, pharmacy play a critical role from early detection, education, and lifestyle consulting. Here, I just want to show some data from Croatia. This slide highlights a major step forward in public health policy in Croatia. The formal integration of family hypercholesterolemia screening into national preventive health screening program. The initiative is from 2023, and they belong now 2026. Then we finish this screening pilot project. The target children are aged 6 to 7 at the point of school entry. And the screening approach includes routine cholesterol testing and diagnosis based on combination of Simon-Broom criteria, elevate LDL cholesterol levels, and genetic testing were indicated. This program reflects a proactive public health model aligned with global best practices. So I'm looking forward for final results. Now I will show you data from 2 years from little county where I live. It's Bjelovarsko-bilogorska county. And the screening program shows us in 23 and 24 that we have the similar number of children who participate in program. But what we found on this screening is that 12% of children had elevated cholesterol, and in first year only 2% were referred to pediatric endocrinology, and in 2024 we have referral rate more than double, around 5%. This increase is very significant. It likely reflects improved interpretation, greater awareness among clinicians, and maybe perhaps a better follow-up system. When you start something, of course, every year is better, and you better in the project. So the findings suggest that as program matured, detection is improved. One more study from Croatia, a cohort study on these findings from studying lipid abnormalities in overweight children and adolescents aged 1 to 19 years old, and all children are overweight. So we have around 500 participants, and we focused on 2 key lipid markers, total cholesterol and triglyceride, and the results are quite concerning. The 17% of children had elevated total cholesterol, and even more striking, 30% had elevated triglycerides. Importantly, nearly 10% of participants had both elevated cholesterol and triglycerides and indicating combined dyslipidemia. This underscores the urgent need for early metabolic screening in overweight children, and especially if they didn't identify and managed earlier. So we can try to prevent cardiovascular diseases in adulthood. It's, of course, important to point of role of the pharmacist. And this slide outlines 5 core pillars of pharmacy-based dyslipidemia care. First, of course, pharmacists are often the first point of contact for families. With proper training and proper tools, we can support lipid screening initiatives, particularly for high-risk children. We can simplify complex information of patient, promote lifestyle changes, and address common misconceptions about diet, activity, and cholesterol in children. We can say that we are key connectors. We can ensure timely referral to pediatricians, endocrinologists, or lipid clinics, so especially for suspected familial hypercholesterolemia. From tracking status of tracking statin used to encourage follow-up appointments, pharmacy can ensure long-term treatment success, especially in adolescents where not adherence is common. So whatever, through school outreach, community events, or social campaigns, pharmacies are we have good position to drive awareness and influence policy. Collectively, these pillars present and represent a shift toward proactive, preventive pharmacy practice, where we don't just dispense, but we actively improve long-term cardiovascular outcomes. At the end, I want to show you a pilot project, what I started a few months ago with my friend Jorge, and we start to investigate the dyslipidemia in pharmacy. So this we try to be primary prevention of dyslipidemia through point of care testing and adherence monitoring. What is the aim of this project is that we offer early detection and lifestyle support, and of course we provide point of care testing and support adherence to we use Adhere 7 questionnaire. And for now, like I said, we start 2 months ago. We have not a really big number of patients, but we start. And of course, when you start something, it's hard, but I hope that we will manage it to the end. For now, we have 30 patients. And what is very important that 30% of them show low adherence and under control cholesterol. And this is our big role that we can support our patient and support adherence. In summary, dyslipidemia in youth is common but often overlooked and underdetected. Obesity increases the risk, but is not only the factor, which is why early lipid screening matters, and we need to advocate for that. As pharmacy, we are in a unique position to detect risk early, support families, and contribute to long-term cardiovascular prevention. So let's use that opportunity to make a lasting impact on pediatric heart health. So thank you very much for your attention, and I will answer the question later.
Thank you so much, Katarina, for this extremely informative presentation. A lot of great information there. And as you said, we will get to the questions later. I'm sure there'll be a lot of questions for you about that. I would like to now introduce our next speaker, Dr. Jorge Robledo. Jorge is a freelance researcher in dyslipidemias and obesity in pediatrics. He is the director of Interinstitutional Program for Prevention and Health Education. He was the director of pharmacy at the Argentine Military Hospital for the United Nations in Haiti post the earthquake. He is author of 6 peer-reviewed publications, had numerous accepted abstracts at FIP World Congresses, and is an international sought-after speaker. Jorge is with us today, but unfortunately, he is not feeling too well, so we do have a recording of his presentation, and Jorge will be available to answer your questions in person later on. Jorge, thank you so much for making the time to join us, even though you're not feeling well. And now I will turn it over to Ines and Albina to play the video.
Good morning to all. Many thanks to FIP for allowing me to give this conference, to Sherif as moderator, to my fellow panelists Katarina, Nesli, Gul, and Victoria, and to Ines Núñez da Cunha for her brilliant organization for this webinar. On the left, I show the logo of my research program called PIPES, an acronym which translates interagency in our interinstitutional program for health prevention and education. It is promoted by the NGO Pharmacists Without Borders of Argentina. On the right figure, with a beautiful slogan that Lars Adgeik Charlen came up with me when I told about my idea. A healthy aging starts with a healthy childhood. With regard to the topic, there are 2 misconceptions that I would like to express. First misconception: high cholesterol is an adult problem. People in general and many members of the healthcare team are unaware that children can be hypercholesterolemic or dyslipidemic. This is a general hypothesis of mine, which is only based on empirical evidence. There are no studies that prove this. For this reason, I tried to see what knowledge and importance the AIs gave of this issue. And I asked this question to ChatGPT, DeepSeek, and Cloud. Question: please give me the names of the fighting risk factors for NCD in order of importance that occur more frequently in childhood and their approximate prevalence expressed as a percentage. Result: DeepSeek doesn't go in the top 15. ChatGPT considered in the 14th position and Cloud in the 12th. Conclusion: these sites don't consider dyslipidemia as an important risk factor for NCDs. The figures show the pathogenesis of atherosclerosis. On the left is a timeline from 0 to 70 years. This girl, in her first decade of life, might begin to develop fatty streak in the artery. In the second decade, she may progress to fibrous plaques. In the third decade, her arteries become more occluded, and she may develop complications such as thrombosis, hemorrhagias, stenosis, or accretion. In the fourth or fifth decade, more serious events such as heart attack, stroke, or gangrene may occur. How can I get this person to reach 88 of the age? I have to start acting for the early years of life. The figure is in black and white. It is a bit strange, but it's very logical. It was published in the middle of the last century in 1958. The subject has been known for a long time. What was not yet known was who was responsible for this process. Who is responsible for this process? Since the beginning of the 20th century, cholesterol has been considered a suspect. Until 1961, when Cullen and Fall him guilty in the work of the Framingham study. This work was pioneering in identifying elevated total cholesterol along with hypertension and smoking as major risk factors for coronary heart disease. Can this factor be present in children? Smoking in children under 10 years of age, very rare. Hypertension, yes. There are between 2 and 5% of children with hypertension, but these are generally very low values. High cholesterol, with this risk factor, the situation is different, and it is present from birth. And this is what I find in children. First, you can see that the cutoff point for children are different from those for adults. It is considered acceptable for those with value lower than 170 milligrams by deciliter. Borderline was likely elevated for those with value between 170 and 119, and elevated for those with value greater than or equal to 200. Next, we will show the result of the sum of the 3 epidemiological studies carried out in the city of Jovita, Argentina, where I live in the years 2009, 2015, 2021, in a total of 188 children from 6 to 12 years of age. First, we show the total cholesterol we give use of 59% of the children with acceptable values, the 29% of the borderline range, and finally 12% as elevate values. If we add the elevate and slightly elevate values, we have 41% of children with unacceptable values. Now let's look the percentage of elevated values of other components of the lipid profile. High triglyceride in almost 19%. LDL cholesterol, better known as bad cholesterol, in number 14%. High non-HDL cholesterol in 50.6%, and low HDL cholesterol, good cholesterol, in almost 19%. As you can see, a very high prevalence. One more thing that is happening particular for a particular reason is the situation particular to city of Jovita. Here we can see that 1,088 children in which this analysis has been made, the average total cholesterol is 166 milligrams by deciliter, and this is practically the same as the world average of 165. In other words, these values shown here are to be expected in almost all countries of the world. Of the 188 children were displayed, where the 332 were associated to 2015. On assumption that the 2015 study was done in children and their respective biological parents, that is showed that hypercholesterolemia in parents is good predictor of hypercholesterolemia in children, that hypercholesterolemia has a strong genetic component, that patient diagnosed and medicated for dyslipidemia regularly visit the pharmacy to pick up the medication, I can be concluded that the pharmacy is the ideal place to try to develop the project proposal fee captcha. Fee is acronym in English of the Pesquisa de Hipercolesterolemia Infanto-Juvenil, and CAPTCHA is in English Children and Adult Program to Cholesterolemia Assessment. Here is something of a story that tries to explain simple how efficacia could be executed. This is a married couple, Evelyn and Kenji. They are Croatian citizens. Unfortunately, they both have high cholesterol. But fortunately, they are diagnosed and medicated. And ever more fortunate because they live in Bjelovar and go to pharmacy Bjelovar to get their medicine. And that is the pharmacy where the lipid pharmacist Katarina Fehir Sola work. When she gives them their medicine, she asks them if they have children, and they reply that they have 3 children. When they asked their children have their cholesterol values measured, then reply that they have not. Katarina then explained about the EPhEU project. The parents agree, and the next step is to make an appointment to test children. Here, Katarina is testing Maja, the older girl, then she will test Kai and Hannah. After, she gives them reports for the physician, refer them the doctor, and give them advice on healthy lifestyle habits with flyer and other physical or digital documents. Result: Maya and Kai also hypercholesterolemic, but Hannah isn't. The advice on healthy lifestyle habits is for everyone because, regardless of the condition, this advice is healthy and therefore beneficial for all human beings. Due to its strong genetic component, screening for all blood relatives suggests, starting with Evelyn and or Kenji, the seed begins. If they were grandparents, children and grandchildren should be assessed. But it's also important to screen siblings, parents, and uncles and blood relatives as long as the values found are outside the normal range. This is called the cascade effect. The second misconception is the relationship between hypercholesterolemia or obesity. In the study in which the lipid profile of the 188 children was assessed, the nutritional status was also assessed. In this contingent table is the reason which I say that obesity is in relation to hypercholesterolemia. The table above shows that of 130 hypercholesterolemia children, only 35 are obese. From another point of view, in the table below, we can see that of 194 obese children, only 34 are hypercholesterolemic. The numerical evidence suggests that there is no relationship between these parameters. Concluding remarks. The pharmacist is facing the challenge of a new PPAs. It is a novel PPA. It is needed and required by lipidology physicians. It is referred as supplement attended by the healthcare team. It is an interdisciplinary PPA. Physicians as pediatricians, cardiologists, endocrinologists, etc., nutritionists, biochemists, and other members of the healthcare team. And the pharmacist could be the leader. The greatest joy of my life is that many, or at least some pharmacist colleagues, like Katarina, will take up the challenge to develop these PPAs, and I'm available to support anyone who wants to try. Thank you for attending.
Thank you so much, Jorge, for this very insightful presentation. And thank you again for being here today and for sticking around, even though you're not feeling well. I would like to now introduce our next speaker, Dr. Nesligul Özdemir Ayduran. Dr. Nesligul earned her bachelor's degree from the Faculty of Pharmacy in 2013 and subsequently completed her master's and the PhD in clinical pharmacy. Her research focuses on pediatric and adult infectious diseases, vaccination in cancer patients, preventive healthcare services, and behavioral theories in clinical pharmacy education, practice, and research. Nesligul, thank you so much for being with us today. The floor is yours.
Thank you very much for introduction. First of all, I would like to sincerely thank the International Pharmaceutical Federation for organizing this important webinar and for giving me opportunity to speak here. I would also like to express my sincere gratitude to Professor Dr. Mesut Sancar, who made it possible for me to be a part of this webinar. Today, I'm going to talk about the role of pharmacists in promotion cardiovascular health, especially lifestyle-based prevention approach for young people. I will focus on why cardiovascular prevention must start early and risk factors for cardiovascular disease development, lifestyle-related risk factors, and finally, the role of the pharmacist in the management of lifestyle-related risk factors. As Dr. Katarina said, cardiovascular prevention should start early because atherosclerotic cardiovascular disease and stroke are leading causes of death globally, and the increasing mortality rate from ASCVD worldwide highlights the need for stronger prevention strategies. And as we know, atherosclerosis begins in childhood, and so early intervention is very critical to reduce long-term risks. As Dr. Jorge said, initiation of and progression of atherosclerosis starts at early ages. Deterioration in the vascular structure begins at early ages. There are well-established risk factors for cardiovascular disease development. These are medical conditions, non-modifiable factors, and these are age, gender, genetic factors, and especially familial hypercholesterolemia is very important in this section. And also lifestyle-related factors are very important. When we look at the lifestyle-related risk factors, these are unhealthy diet, obesity, physical inactivity, alcohol use, and smoking. Unhealthy diet is the first risk factor for cardiovascular disease development. Children's eating habits play a crucial role in shaping their overall well-being and their health, and not only their physical growth, but also emotional and psychological development. Unhealthy eating habits in childhood can lead to obesity, diabetes, and cardiovascular diseases in adulthood. So early interventions are critical to prevent lifelong health issues. Negative emotional states are linked to unhealthy eating behaviors. Factors such as parental feeding, peer pressure, socioeconomic status, and body image influence eating habits. Studies show that older girls show higher tendencies toward dieting and food preoccupation. Also, age, gender, and emotions are closely interconnected. There's a study about this topic, the effect of a student pharmacist-directed program for elementary school children. This study assessed children's understanding of health topics after pharmacist-led sessions. These interactive sessions covered some special topics such as nutrition, physical activity, summer safety, hygiene, medication safety, and tobacco prevention. Sorry. Okay. When we look at the results, 304 elementary students participated in the study, and overall elementary school students had a positive improvement in knowledge for all health-related topics. However, not all were statistically significant. Significant improvements in knowledge were observed in specific age groups and in specific topics such as medication safety, tobacco prevention, and benefit of increased hydration. Obesity. Childhood obesity is a growing public health concern, and it is a strong predictor of adult obesity and related cardiometabolic complications. Studies show that 55% of obese children become obese adolescents, and 70 to 80% of obese adolescents remain obese in adulthood. And the risk of non-fatal and fatal coronary heart disease was positively associated with body mass index in childhood from age 7 to 13 in boys and from 10 to 13 in girls. Children and adolescents with obesity have approximately 2.5 times higher risk for dying from ASCVD compared to peers with a normal weight. Pharmacists can play a key role in raising awareness and promoting health lifestyle changes. Since both prevention and treatment focus primarily on lifestyle modifications, pharmacists are in a strong position to provide guidance during their routine interactions with adolescents and parents. Educational efforts should target both children and families, emphasizing healthy eating, portion control, and regular physical activity. There is a study about in this topic, pharmacist's role in weight management. In this study, it was evaluated pharmacist beliefs, practices, knowledge, and services related to weight management. It was a national cross-sectional survey, and when we look at the results, it's found that 80% of pharmacists believe that they play a vital role in weight management. However, 50% of pharmacists have a lack of trust in regulation of weight loss products. When their professional involvement were analyzed, they showed a high engagement in product sales, diet counseling, physical activity advice. Despite these high engagement in these activities, 50% of pharmacists said that they rarely or never calculate body mass index. When their knowledge about weight management evaluated, there are some key predictors of higher knowledge. These are holding a master's or PhD degree, local pharmacy education, academic training in weight management, and frequent patient inquiries. The other risk factor is physical inactivity. Healthy nutrition and regular physical activity are essential for preventing and treating pediatric obesity. Daily sedentary behaviors are associated with higher fat mass and cardiometabolic risk in children and adolescents. Many adolescents in European countries and in America spend 9 hours a day being sedentary. In fact, this is not surprising because they grow up in a technology-rich environments that encourage screen time beyond school, such as TV, video games, smartphones, or tablets. And it is well known that high screen time was strongly associated with increased food intake and unhealthy eating habits. European childhood obesity groups strongly encouraged the developing individualized sustainable interventions targeting sedentary behaviors, evaluating children's physical activity and sedentary behavior patterns, and conducting well-designed studies. There is a step-by-step approach for these. The first step is reducing sedentary behaviors, then introducing structured supervised physical activity programs, and finally perform medico-economic evaluations. There is a meta-analysis about effectiveness of lifestyle interventions in preventing or managing childhood obesity. This study included 53 studies, and when we look at the main findings, according to 31 studies, there isn't a significant effect. There isn't the interventions doesn't have a significant effect on body mass index, and there isn't a difference based on intervention duration, intervention type, or baseline weight status. But on the other side, 19 studies reported reductions in body mass index, and 11 studies showed improvements in cardiometabolic risk factors. In conclusion, this study showed that combined physical activity and nutrition approaches are most promising for reducing obesity-related comorbidities. Alcohol consumption is another topic, and we know the association between alcohol consumption and cardiovascular disease is complex and controversial. Some studies suggest that light to moderate alcohol intake may be associated with a lower risk of certain types of cardiovascular disease. Long-term excessive alcohol use significantly increases cardiovascular risk and mortality. And the World Health Organization has stated that no level of alcohol consumption is safe for health. When it comes to children, no amount of alcohol should ever be consumed because people who start drinking earlier in life have a higher risk of using alcohol excessively or developing alcohol use disorder later in life. When we look at the factors that lead children to start drinking alcohol, social learning plays an important role. Children often view their parents' alcohol use as a model of acceptable behavior. So, access to alcohol in the home and parental permissiveness of alcohol use are factors associated with drinking by children. A randomized controlled trial was conducted to examine the impact of pharmacist intervention on alcohol use in adults. Participants randomized to either brief intervention group or a leaflet or control group. Hazardous or harmful drinking was assessed using these tools administered by telephone or by a researcher. The main outcome is the primary outcomes were change in these test total scores and the proportions no longer hazardous or harmful drinkers at 3 months. The results are very striking because pharmacist interventions didn't show a significant effect on alcohol use. Still, this is a valuable study because it shows that we are lacking in this area and needed to rethink our current approaches. Smoking, it is another major risk factor, and unfortunately, it often begins at an early age. According to the National Youth Tobacco Survey, 8% of all students use tobacco products. Among them, 5% of them are middle school students. Among tobacco products, e-cigarettes have emerged as a major and concerning issue among today's youth because this growing public health crisis is driven by high nicotine content and a wide range of flavors appealing to young people. While many studies examine pharmacists' role in adult smoking cessation, research in adolescents is limited. But I want to share studies results with you. In this study, it was aimed to evaluate adolescents' perceptions of the teen e-cigarette and vaping educational research. It included 35 adolescents, and participants took part in semi-structured individual interviews. The focus was on understanding how adolescents perceive the tool and their views on learning about vaping from health professionals. Adolescents found this tool engaging and informative. Some participants expressed a desire for more detailed information, and most participants wanted to learn about vaping from a healthcare professionals, especially from a pharmacist. However, they note some potential challenge to implementation in community pharmacy settings. In conclusion, this tool was well received and shows promise as an educational and preventive research. To summarize this presentation, pharmacists can play a critical role in promoting cardiovascular health in children through a variety of lifestyle interventions. Although as pharmacists, we have the potential to influence many aspects of lifestyle changes in children, I have realized that our involvement in this area remains limited. As a pharmacist, I really believe that there is still so much we can do in this field, such as conducting well-designed interventional studies, integrating pharmacists into school and community-based prevention programs, developing and validating age-appropriate educational tools, and promoting interdisciplinary collaboration between pharmacists and other healthcare professionals. In conclusion, it is clear that pharmacists have a unique opportunity to contribute to prevention of cardiovascular disease starting from an early age. But more research and collaborations are needed to establish a strong impact. Thank you very much for your attention.
Thank you so much, Dr. Neslegul, for this excellent presentation. I would like to now introduce our next speaker, Dr. Victoria Cardenas. Victoria is an associate professor at the University of Granada in Spain and an adjunct fellow at the University of Technology, Sydney, Australia. Her teaching and research interests encompass different aspects of health services research, including the evaluation and implementation of services aiming at optimizing medicine's use. She has co-authored over 80 papers in refereed journals and 85 conference presentations. Victoria has participated in a range of national and international research projects for the evaluation and implementation of professional services in community pharmacy. She is the chair of the Pharmacy Practice Research Special Interest Group of FIP and also serves as an associate editor for the journal Research in Social and Administrative Pharmacy. And she has been appointed as an external expert of the European Commission. Victoria, thank you so much for being with us today, and I will now turn it over to you.
Thank you very much, Sherif, for your kind introduction. And hello, everyone. Before I start, I would like to thank the organizers of the webinar and FIP for giving me the opportunity to share my experiences here today in this very relevant webinar. My presentation outline for today, as you can see on the screen, I will cover firstly the evolving role of pharmacists in cardiovascular prevention across the life course and how we can support that evolving role. I will then move into the barriers to implementing different services in pharmacy, and I will finalize with policy and advocacy strategies to integrate pharmacists in this very important role. Before I start, I would like to highlight the importance of evidence-based pharmacy practice. So, as you can see on the slide, evidence-based pharmacy practice ensures healthcare decisions are based on current, valid, and relevant evidence. We've seen from the previous speaker the different evidence available that is out there and that we should be using to improve our practice as pharmacists. It enhances the quality of patient care, and it also enhances different intermediate, like, for example, LDL levels, or ultimate, for example, mortality outcomes. So how we can contribute to that and what to expect from the services that we provide. It supports the further development of pharmacist-led services and interventions beyond to the ones that are already being delivered and implemented, and it also influences policy and funding decisions for sustainable healthcare models and contribute to the sustainability of healthcare systems. How can we support the evolving role of pharmacists? So the population is changing, the context is changing, and the role of pharmacists is also changing. So before we start or develop new services addressing those changes, we should undertake a health needs assessment. This is identifying or the systematic method to identify unmet health needs of a population. So why is this important? Firstly, because it guides the development of pharmacy services and we ensure those services are aligned with social needs. And in that way, we can ensure the sustainability and relevance of those services and their integration within the healthcare system. Unless those services or pharmacy services that we develop are covering and addressing those unmet population needs, we cannot ensure that those services will be sustainable over time. So how do we usually undertake a needs assessment to support the evolving role of pharmacists in cardiovascular prevention? So firstly, we should be assessing local, community, and global environments. How do we do this? Firstly, we can adopt an epidemiological approach to the problem. So for example, assessing, investigating, searching the evidence of the prevalence of dyslipidemia in children, which has already been covered. Secondly, we should be focusing on the needs of individuals, communities, and also population. So if we are aiming to implement a service in a rural area of Australia, what are the needs of the population? What are the needs, for example, of Aboriginal children living there? And in that way, we can ensure that stakeholder engagement is ensured and that we really have a community orientation. We are addressing community needs. Secondly, we should recognize the dynamic and diverse nature of needs. Those health needs in the community and population can be objective. So for example, high LDL levels, or subjective. So for example, low perception of future cardiovascular risk in young people, which is usually low. These needs can also be physical. So for example, a very sedentary lifestyle, as Nestle Gold was highlighting before, or psychological. So for example, smoking, alcohol addiction. And these needs are likely to change over time. So as I was mentioning before, the context changes, the population changes, the demographics, the social determinants of health, access to digital tools, those are continuously changing. And in the last 10 years, they are changing very quickly. So we should be aware of those changes to adapt our professional role and develop new services targeting those changes. Thirdly, we should ensure a continuum of care with different services in cardiovascular prevention and management, which range from prevention and screening to management and even palliative care. And this should be developing or targeting, we should be developing services, integrated services that ensure that continuum of care with different services ranging from illness prevention, health promotion, public health and screening to even palliative care, amongst others. And we should also be able to deliver services that respond to current public healthcare crises. Unless we undertake an effective needs assessment, we can, or if we undertake and we develop services, we provide as pharmacy services that are targeting, addressing those needs, these services can even lead to the integration of planning, commissioning of services by public authorities. So for example, pharmacies in Germany are now reimbursed to control and monitor blood pressure. And lastly, we need to analyze social and environmental determinants of health. So we need to carefully examine and fully understand what is affecting the problem. So what is affecting cardiovascular risk in young people, in children? So is it weight, parental education, nutrition, access to unhealthy food in schools? And what interventions are we going to develop to address those determinants of health? Can they be targeted with a pharmacy services? Would those services be within the scope of practice? Should we expand the scope of practice of pharmacists? So those are all the questions that we need to answer when developing, identifying and unmet health needs, and then developing new pharmacy services that target those needs. We have evidence, a large body of evidence of the role of pharmacists in different management, screening, prevention of different cardiovascular conditions. However, most of these are targeting adults. We have limited evidence, as the previous speaker was highlighting as well, in children. Nevertheless, as it was highlighted in this paper reference here, once we have services which are reimbursed or integrated into daily practice, we do need implementation programs to achieve an effective integration of those services in the practice of pharmacists and achieve their long-term sustainability. And this is one of the major failures that has been identified when when trying to change the scope, the practice of pharmacies, which is becoming more patient-oriented over the past few years. So this leads to my second topic, which is barriers to implementing different screening services or prevention services in pharmacy. As you can see on the slide, this is the consolidated framework for implementation research, which is one of the widely used determinant frameworks used when trying to implement innovations in any setting. Not only, this is not exclusively for pharmacy, but it has been widely used in this setting. So as you can see on this screen, there are different constructs, which are factors that affect the implementation of different innovations in a given setting. So if we focus on pharmacy, the implementation of services, of professional services into community pharmacy. So these constructs, these factors affecting that implementation are distributed across different domains. The first one is the thing being implemented. So in our case, it would be the pharmacy services, the pharmacy service aiming to prevent or screen patients with cardiovascular diseases. The second level would be the setting in which we are trying to implement the innovation, in this case, the setting in which the pharmacy exists. Following level would be the pharmacy, and fourth level would be the individuals involved in the implementation process. So the roles and characteristics of individuals involved in pharmacy, including patients, the recipients of those services. And finally, it would be the process, the implementation process. So this is the activities and strategies to implement the service. So if we are looking at those different constructs, including at those different levels, you can see the complexity of implementation, of introducing changes into a hospital pharmacy, into a community pharmacy. And we carefully need to look at those constructs, at those determinants affecting the implementation of services if we really want to achieve an effective and sustainable implementation in community pharmacy, for example. There is limited evidence of those barriers affecting the implementation or moderating the implementation of services targeting children or young people in pharmacy. However, we have some evidence for services in general or services targeting adult patients. So as you can see on this slide, factors affecting or related to the service itself are included or have been defined in the literature as the complexity of the service to be implemented. So how complex is it to be delivered, the cost of being implemented, and if it is an evidence-based service or if it's just something that a policymaker, a professional leader thought of and it was implemented without evidence. Then regarding the outer setting, this is the setting where the pharmacy is located. Different barriers identified include GP responsiveness and lack of collaboration with local pharmacists to deliver or collaborate in sharing patients, lack of integration of the pharmacy and coordination structures with other healthcare professionals and communication channels, and of course, the widely identified lack of remuneration for pharmacies for delivering those services, which definitely affects its sustainability long term. If we look at the inner setting, this is factors or barriers located in the pharmacy itself, where we are trying to implement cardiovascular services. We can identify lack of time, inappropriate workload in the pharmacy that doesn't allow for coordination with the different staff working in the pharmacy and activities to be performed, the relative priority of implementing and delivering the service within that pharmacy, and of course, resource limitations. So for example, lack of computers, lack of counseling area, monitors, etc. If we focus on the individuals, there are two barriers that are frequently identified. The first one is pharmacies' low self-efficacy and motivation to deliver the service. Some pharmacies think they don't have the skills, training, knowledge to deliver these kind of services. And then patient engagement and motivation with preventive services. So when patients have not developed any condition yet, they don't usually feel as engaged with services which are aiming at preventing the disease from occurring. And finally, in the implementation process, so the strategy is put in place to implement a new service into a pharmacy, into a given setting. We identify the lack of robust and evidence-based implementation programs and strategies. So implementation programs, I hope I gave you like an overall idea. Implementation programs are complex and they need to target many constructs. It's not about just paying pharmacists, just training pharmacists, which was the old approach. It's about considering, as you could see, different constructs at different levels and developing evidence-based implementation strategies targeting all those constructs to ensure proper sustainability in the future. And final topic, it would be policy and advocacy opportunities to integrate pharmacy in early cardiovascular diseases and prevention strategies. This framework that you can see on the slide is a framework that we developed a few years ago, trying to ensure the sustainability of services in community pharmacy long term. So as you can see, we have different levels, which is when we talk about sustainability, everybody thinks about economic performance, which is obviously important, but we often forget about the social performance of the service and the environmental performance of the service. And this is where policy and advocacy opportunities come in place and strategies. What can we do at a policy level? So for example, we should advocate for the inclusion of pharmacies in national cardiovascular prevention guidelines to explicitly include pharmacies. We can see examples of NICE guidelines which are increasingly referencing and other national guidelines which are now increasingly highlighting the role of pharmacies. We need to introduce or expand remuneration for pharmacies-led cardiovascular screening, like for example with blood pressure monitor, LDL, cardiovascular risk scoring, and also follow-up services. So, for example, the service that I already highlighted, BP monitoring in Germany. We need to formally integrate pharmacies in multidisciplinary cardiovascular prevention teams at primary care level. And we can see some examples in New Zealand with long-term condition pharmacy services integrating with general practice. We need to expand the scope of practice, so update legislation to allow pharmacies order lab tests, refer directly to specialists like cardiologists, which in most countries we cannot do. And then we need to support digital infrastructure and interoperable digital systems so pharmacies can contribute to access and complete patient data. Again, BP level, check LDL levels, smoking status, etc. And we can see some examples in different countries. And finally, what are the advocacy strategies that we can implement to integrate pharmacy in early cardiovascular prevention? So, for example, participate in public awareness campaigns, including pharmacies. So, for example, the cardiovascular disease prevention campaigns led by pharmacy organizations, pharmacy and the World Heart Day, My Measure Month, in which some pharmacists in Canada participated a few years ago. So be there, be included in those initiatives. Engagement with medical associations and cardiologists. So, for example, advocate for joint position papers or position statements between pharmacy and cardiology societies. So, for example, ESC and national pharmacy bodies to promote shared care and highlight the importance of including pharmacies in that multidisciplinary care team. We need to use evidence. We need to disseminate the data showing the effectiveness and cost effectiveness and clinical impact of pharmacy-led services targeting cardiovascular prevention. So we have very good evidence, for example, in Canada with the RITS project. We can also use PCAPSA specifically for young people. And finally, incentivize pharmacy schools and other professional associations to improve and increase the professional training and competency development in cardiovascular disease prevention and management. So my final remarks, I think, or I believe there is a lack of holistic implementation programs which hinder the implementation of these services in daily practice. We need ongoing evidence to support service remuneration at local and national levels. There is also a need to integrate pharmacies in multidisciplinary teams managing cardiovascular conditions. And I think pharmacy practice research is key to enable the sustainability of these services long term. So thank you very much for your attention.
Thank you so much, Victoria, for this very informative presentation. And thank you again to all our speakers for your great presentations and for sharing your valuable expertise and insights on this important topic today. I'm sure there are a lot of questions from our colleagues listening, so we will now open the floor for your questions. Reminder that if you have a question, to please write it in the question box, and we will make sure to get to it. So I see that we already have some questions here. So I think the first question is, I think it was already taken. Apart from statins, are there other classes of drugs used for treating hyperlipidemia in children and young adults? So that will be open for everyone from the speakers. And maybe if I can ask all the speakers to please turn on your camera. That's legal, Katarina? Excellent, perfect, thank you. So for that question from Jeffrey, any one of you would like to tackle that one? So I'll ask the question again. It's apart from the statins, are there other classes of drugs used for treating hyperlipidemia in children and young adults? Ori, I see you're unmuted. Are you trying to speak? Is the voice coming? Inesh, are you able to hear?
No, I'm not hearing. So maybe we can move to another question?
Maybe, okay. So Jeffrey will make sure to get back to you on that one. There were some questions that were answered already, but I'm not sure if everybody would have had the opportunity to necessarily read all of those responses. So I think one of the questions that was asked from Vivek and Nestle Gul, you did put that in the chat, but maybe for everyone's benefit, if you can speak a bit more to it. The question is, considering the long-term cardiovascular risks associated with undiagnosed dyslipidemia in children, what strategies would you recommend for pharmacists to proactively engage in early detection, especially in low-resource or rural settings?
Thank you for this question. In fact, I gave an answer for this at the chat box, but I think there are some activities that we can do as a pharmacist. We can counsel families, we can counsel parents about cardiovascular risk and early diagnosis about these cardiovascular diseases. And after this counseling, I think they will be alert for this topic, and I think this is a very easy intervention to do, and I think all of us can do this intervention.
Perfect. Thank you so much. And maybe a question for Katarina. How can pharmacists and the healthcare system be motivated to support the broader implementation of the point-of-care testing and the pharmacy-based screening testing in practice?
The motivation is always a big topic, and some of this Victoria already answered it. So I think it's very important to pharmacists be involved in strategies of health and be more in collaboration with doctors in this crucial point. So maybe they will motivate it. Of course, reimbursement and policy support is also very important. And we know that in countries, additional services are not paid, so it's not motivated. But always you have some people who want to do something more because their pharmacy said they want to use the knowledge and competencies to start maybe pilot project and another thing. So I think also is motivating continuing education and of course promoting pharmacy role.
Perfect. No, thank you so much. Victoria, in your presentation, you did speak a lot about remuneration and reimbursement, and I was very happy to hear that because we don't often talk too much about it. And the fact is, it is something that is certainly very, very important to have. So from what you've seen, obviously, it's not always an easy conversation to have, and it's not, especially with public payers and also with private payers, and in some cases where the services are not supported, asking for patients to pay for it. So there are so many different points here. The first is, how do you see the pharmacy practice research supporting this particular point in terms of advocacy with payers, public or private, to be able to make the case for reimbursement of expanded scope of practice? And the other part is, where it's not covered, how do you manage the getting the pharmacists into the mindset of being comfortable to charging patients for that?
Mm-hmm. Thank you, Sherif, for the question. It is very relevant because without remuneration, there is no long-term sustainability. So that's the reality. Even though we can see many pharmacies at the initial stages doing some services without remuneration, they are never sustainable long-term. I think pharmacy practice research is doing a good job at contributing, highlighting, adding evidence, supporting with economic analysis and very good economic. We've seen in different countries, we have the evidence. We know how much a service to be delivered costs, and then we know how much it is saving to the healthcare system. So it is, if you are able to, or if you are able, like then advocacy organizations and policymakers are able to negotiate with payers to achieve that payment based on evidence. Look, if you pay €1 for X for this service, the return of investment in the healthcare system is going to be multiplied by 2. So I think it's holistic approach to the negotiation. On one side, you have pharmacy practice generating all the evidence, but if that evidence is not used to negotiate by other stakeholders, that payment, it is not enough. So it is a holistic approach to the process. And I don't think there is sustainability without payment.
100%. Yes, of course. No, and I think obviously there are a lot of lessons learned from different countries and jurisdictions around the world that we can share. So you not necessarily have to duplicate the work, and you can take advantage of that. It's one of the benefits also of being part of an organization like EPhEU, because one of the key messages which we all need to be sharing as pharmacists globally is that an investment in pharmacy is an investment in healthcare. And basically, it's important to try to get governments and the policymakers not to look at pharmacy as a cost center, but really more as a part of the solution. So I think it's a very, very well said. I see we have a couple of minutes left, so I just want to give a quick opportunity for anyone from the speakers, if you have any last takeaway messages or any final remarks you'd like to make, just 10-15 seconds. Okay, perfect. So with that, I would now just like to first remind you that EPhEU has a lot of resources on cardiovascular disease. If you would like more information on that topic, please make sure to check the EPhEU publications, which include a handbook for pharmacists, a knowledge and skills guide, and you can find those on the EPhEU website, and you can see the URL on the slide here, or you can scan the QR code. Also, a reminder that if you wish to listen to today's webinar again, and there was certainly a lot of great information shared, I'm not sure if you're able to catch all of it at once, but if you'd like to go back and revisit the webinar, you can do so. It is available on our website at events.fepu.org and also on the YouTube channel. And also, when you're on our website, please make sure to check our upcoming events and to register for them. And of course, we want to take this opportunity to invite you to join us at the next FAP Congress in Copenhagen, which is happening next month. It's a great opportunity to network with colleagues from around the world and to learn and share best practices. So please make sure to mark it in your calendar. And if you would like to learn more about the Congress, please visit the website on the screen, which is copenhagen2025.fip.org. And if you're able to join us, make sure you take advantage of the second registration deadline discounted fee and register before August 11, and certainly hope to be able to see you there. And with that, we are now at the end of our event. Thank you so much again to our fantastic speakers. And thank you everyone for making the time to join us today. Hope you enjoyed the